My name is Kendall Burdett, and I'm a graduate student for the Masters of Health Administration program at the University of Southern Indiana. The primary focus of this research is to economically evaluate a potential intervention regarding nuclear medicine cardiology and the radiation exposures involved in a myocardial perfusion imaging stress test. A new advancement utilizing new technology has enabled medical personnel to employ NPI stress-only testing. This economic evaluation will identify the underlying problems in NPI stress testing, introduce the possibility of new interventions, compare and contrast other options that could solve the problems with radiation exposure, and the desired outcomes of this economic research. To begin the framework of the economic evaluation, a PICO formatted question helped construct the evidence behind the need for an intervention. The first step was to identify the problem. The problem is the unnecessary overexposure to radiation and myocardial perfusion imaging rush stress testing. New advancements in nuclear medicine cardiology have created an intervention that may be possible to implement throughout all nuclear testing known as stress-only imaging to reduce the total radiation exposure and time throughout the process. Comparison to other interventions that may be used would be to focus on appropriate use criteria when ordering NPI stress tests. The wanted outcome and interest would be to overall reduce total radiation exposure in NPI stress tests, decrease healthcare costs, and increase time efficiency. Unfortunately, the United States has seen significant prevalence of coronary artery disease. The underlying drivers of this are lack of nutrition, increase in sedentary lifestyles, and non-compliant patients. With the rise of coronary artery disease, cardiac diagnostic testing has taken a major hit as the past 2 decades have seen nearly 60% increase in ordered testing. According to research by Dr. Gupta and Dr. Bajaj, around 87% of these cardiac tests involve some type of imaging of the heart. Although these advancements have led to medical breakthroughs in cardiology, the tests are being performed on younger patients now more than ever. The need to reduce radiation exposure is critical. There is a lack of knowledge of the biological effects with radiation exposure, but what literature does state is prevalence of cancer due to radiation exposure is significant. During an NPI rest stress test, this diagnostic exam involves the use of a radionuclide isotope and stressing the heart to evaluate functions and hemodynamics of the cardiovascular system. This process usually takes about 2 to 3 hours. The patient is initially injected with a lower dose of radiation, and then images are captured of the tracer flowing through the heart by a SPECT camera. The patient will then be stressed either by exercise or a pharmaceutical with a second higher dose of radiation to circulate through the body. The stress imaging then will be captured as the radionuclide isotope flows through the heart after being stressed. A change in blood flow from the resting to stress imaging may indicate ischemia. The advantage of the NPI stress test is that it is less invasive than open heart surgery or a heart catheterization. The population that this problem is mostly affecting is individuals that are younger in age, which typically less than 65 years old, or low to moderate risk of having ischemia. An individual is considered low risk based on their age, no history of heart problems, no family history of heart problems, negative troponin levels, and no EKG changes that indicate ischemia or a myocardial infarction. Usually these patients tend to have an NPI stress test as a rule-out test rather than the need for the test. There can be some cases where it would be appropriate as a rule-out test, but usually this is in individuals with at least one risk factor, such as hypertension, current smoker, diabetic, or certain arrhythmias. If the individual has a low risk to indicate ischemia, this deems the test having higher risk than the benefit of a diagnosis, leading to overexposure of radiation. Intended population of this economic research is meant for the Heart Hospital Administration and cardiology, and to possibly develop a new protocol or policy involving the appropriate use of NPI stress testing. A new cardiology diagnostic imaging advancement has taken center stage, also known as NPI stress-only testing. Currently, 7% of non-invasive cardiology testing utilizes stress-only protocols. This stress-only procedure is similar to the rest stress, but the patient will not have to have the rest imaging completed. The patient will begin the test by first stressing the heart with either exercise or a pharmaceutical. The radioactive isotope will be injected at this time with a dosage of 10 millicuries. The blood flow will then be captured after the heart has been stressed with a SPECT camera. This test will last approximately 60 minutes, nearly decreasing the time of the test by 60%. If the stress image indicates there are ischemic changes, the cardiologist will determine to either process additional rest imaging for the next day with a radiation dose of 24 to 36 millicuries or proceed to a heart cath for the patient. This intervention has known to have many benefits of decreasing cost and radiation exposure. In a study at Mount Sinai Hospital, 250 NPI stress-only tests were administered. 203 of the 250 patients in this study had normal stress images and did not require rest imaging or further treatment by the cardiologist. It was later determined 7 of these patients were misclassified that needed even further treatment or resting imaging. As previously indicated, the total radiation exposure in a stress-only compared to a rest stress shows significant differences. NPI stress test is known to be one of the most common cardiac diagnostic tests with the highest radiation burden in the United States. Why hasn't anything been implemented to lower this? An interview with the Heart Hospital's nuclear medicine technologist, who is certified in cardiac nuclear medicine, indicated that the Heart Hospital NPI stress consists of almost 50 millicuries of radiation exposure. Most studies that have explored the use of NPI stress-only imaging utilizes about 10 millicuries total in the full test. This shows a reduction of almost 80% in radiation exposure. The contraindication of utilizing a stress only over rest stress is if both tests give the same results with a high sensitivity rate. The target population of stress-only imaging would be nuclear cardiology throughout the United States, with evidence that this test has shown reductions in not only time consumption, but radiation exposures in cardiac diagnostic testing. This graph shows a comparison of different data demographics involved in the NPI stress-only test and NPI rest stress test. This data was pulled from a research study from Mount Sinai Medical Center from 2004 to 2006. Patient volumes were 2,436 patients in the stress-only category and 8,173 patients in the rest stress test category. The radiation dosage in the NPI stress-only was 75% lower than the NPI rest stress test. Normal perfusion was indicated in 2,193 patients in the NPI stress-only test, as 4,615 patients were indicated to have normal perfusion in the NPI stress test. After a 5-year follow-up, 7 of cardiac deaths occurred in the NPI stress-only test, as 17 cardiac deaths occurred in the NPI rest stress test. This data shows that both tests show similar percentages of patient demographics. What this indicates is that the stress-only test is just as capable of diagnosing ischemia in the heart just as rest stress testing would do. The main focus of this research is to economically evaluate NPI rest stress test to NPI stress-only test, utilizing different economic models and equations to determine efficiency of the posed intervention. This economic evaluation continues as this slide will discuss the supply and demand involved in NPI rest stress testing. Currently, defensive medicine has become a known factor in driving not only cardiology ordered tests, but healthcare procedures in general. Defensive medicine is known as medicine ordered for a patient that might not be in the patient's best interest of care, but to cover the physician's liability in medicine. For example, there have been many cases in the Heart Hospital non-invasive where a physician has ordered an NPI rest stress test on a patient that has come to the ED complaining of atypical chest pain. Atypical chest pain is determined as chest pain that is usually caused by something unrelated to the heart. These patients do not have any other indication of ischemia. Then why are these patients ordering a test that has more risk of radiation exposure than benefit of diagnosing coronary artery disease? There are other diagnostic testing that utilizes less radiation and can give us a clearer indication if the chest pain is heart-related or not. Unfortunately, the idea of defensive medicine is likely to stay due to medical personnel being human. Humans are known to make mistakes, and they aren't perfect. Mistakes can happen, and legal counsel is there to help when this occurs. This does give some backbone for patient safety. However, this may induce ethical issues within medicine as physicians are commonly ordering unnecessary tests for patients that don't need it, causing unsurmountable debt from medical bills and medical expenses. Due to an increase in patient volumes of cardiac diagnostic imaging, the supply of radiation doses have been struggling recently to keep up with the number of tests being ordered. In January of 2018, the Heart Hospital Non-Invasive was unable to perform outpatient NPI rest stress tests due to a shortage of radiation doses around the United States. Therefore, only stat-ordered NPI rest stress tests were only performed for 3 weeks. Does nuclear cardiology foresee a shortage of radiation dosing in the future? Absolutely. At this rate, the likelihood of an increase in demand and not enough supply will impact nuclear cardiology significantly. If cardiac diagnostic testing wants to utilize nuclear imaging with stress tests, something needs to be implemented in order to supply to meet demand in equilibrium. An education platform will help in enforcing the need to appropriately order these tests for all physicians, especially in emergency medicine and cardiology. Although there is a lack of knowledge involved in biological effects of radiation on the body, there is enough evidence in literature to know it does significantly increase an individual to develop cancer. In this slide, a Markov cycle decision tree is showing the process and outcomes of each test when a patient initially complains of chest pain. This decision tree uses data pulled from a study performed for a 26-month period conducted by Mount Sinai Department of Cardiology. A total of 10,609 patients were seen due to recurring chest pain. Of this population, 4,910 patients were deemed as appropriate for the study, which the target population was low to moderate risk patients. 66% had NPI rest stress tests, as 34% had NPI stress-only test. This is the initial decision process performed by the ordering physician to determine the plan of the initial action as the patient is complaining of chest pain. The next step will be the next terminal of the indication that the patient lives or dies. This data is after 1 year. In stress only, 1.2% died and 98.8% lived. And the NPI rest stress patients, 1.2% died and 98.7% lived. After a 5-year follow-up, the individuals who survived, the data shows that there is similar patients who survived and died in both tests. This process breaks down to show that the decision process, which evidently shows that similar outcomes are to be expected when choosing either the NPI rest stress or NPI stress only. Please advance to the next slide to see other evidential data to support the new intervention. A cost-effective analysis is a way to quantify trade-offs in the medical industry by comparing resources utilized and health outcomes achieved. In this cost-effective analysis, the resources being evaluated are radiation exposure, cost of the test, and time consumed for each test to be performed. The health outcomes achieved are a negative test that is actually negative while obtaining the quality-adjusted life year. In the table here, the radiation dosage amount is an estimate pulled from multiple studies. The NPI stress-only test gave an estimated 75% reduction in radiation exposure, 60% decrease in time utilized, and $3,600 decrease in cost. These each show a significant benefit that can justify the risk involved. As previously stated, if the stress images come back as positive for ischemic changes, which is a common indication of coronary artery disease, the cardiologist will then decide whether to order the patient additional imaging if no previous images exist, or order a heart catheterization. Through interviewing many cardiologists that work for the heart group at the heart hospital regarding stress-only tests, a main concern was having the patient have to come back for an additional scan that requires more radiation injections. However, many studies have shown that even though some patients do indicate a need for additional images, there is still an overall reduction in radiation utilized in these tests, as most of the patient's stress images would show normal perfusion. So, how does the previously explained cost-effective analysis impact MPI stress tests for nuclear cardiology? Evidence will justify that the intervention both reduces costs and efficiently provides enough evidence to diagnose the presence of ischemia if it is there. The heart hospital currently has not adopted MPI stress-only tests, so the cost was extrapolated from the cost of the MPI rest stress test and discussions with the manager of the heart hospital administration, Stephanie Druin. The clinical effectiveness are both similar in the same health outcome through the data from previous slides. From this, an incremental cost-effectiveness ratio was calculated by comparing the difference in cost of each test to the clinical effectiveness of each health outcome from each test. The ICER resulted in $3,700. Again, each diagnostic test share equal benefits, however the stress-only test is cost and beneficially competent. Why hasn't cardiology adopted this sooner? Although it seems like a simple idea, why not begin performing stress-only tests tomorrow? However, there is a long process in changing such a protocol by passing it by the administrators, the board of directors, the board of cardiology, and the non-invasive itself. To further justify the MPI stress-only test, the test itself has been approved and currently been practiced in some cardiology clinics around the United States. However, most of the hospitals that have implemented this protocol are larger hospital corporations and teaching hospitals due to large patient volumes. The safety of this protocol has been validated through studies conducting stress-only protocols since the late 90s through the U.S. Evidence from similar research has proven that the sensitivity of the stress-only is equivalent to the outcomes of the rest stress test. A literature review conducted by Desprez et al. Found that 9 out of 10 patients with coronary stenosis is noted in SPECT stress imaging. This evaluation also discovered that patients with normal SPECT studies have an annual risk of a cardiac event of approximately 1%. The shortcomings of MPI stress-only tests is the lack of significant research to implement in all cardiology non-invasive testing clinics. Another economic downfall is insurance coverage. Many patients will seem to face a problem with insurance approval for pre-certification. The insurance may pre-approve a stress-only test, but if the physician is wanting to obtain additional rest imaging, then the insurance may not cover that portion. Also, some hospitals may run into the issue of reimbursement of this test. Due to the lack of stress-only testing around the U.S., the reimbursement rates may not be as efficient as MPI rest stress test. Insurance policies are unaware of the health outcome benefits from utilizing stress-only tests. So if an education platform is delivered, this may change and increase the reimbursement rates from the indications found in the cost-benefit analysis. There are available alternatives that can be utilized for the time being to maximize quality healthcare and lower costs for the patient. Providing appropriate use criteria for all physicians regarding MPI stress testing would benefit all medical personnel and patients. A diagram to the right shows a draft process when considering choosing appropriate treatment plans. This breaks down to positive ischemic indications and negative ischemic indications. An interview with a cardiologist at the Heart Hospital, Dr. Penny Metza, shared some very insightful information. Dr. Penny Metza's feelings towards stress-only protocols are very proactive, as he agrees that there is a high rate of unnecessary tests being ordered every day. He also argued, if the patient is low risk to begin with, why is there a need to add imaging? Why can't the patient just have a normal exercise stress test to evaluate blood pressure, EKG changes, and heart rate that can just as easily indicate ischemia? He stated that those patients shouldn't be receiving that high of an amount of radiation to begin with. Another study involves stressing the patient first. If the patient reaches 85% of their maximum heart rate with no symptoms of ischemia and no EKG changes, then the test would be deemed as normal. If there was any indication of ischemia, the nuclear medicine technologists would inject with the radioactive tracer and obtain stress images. The issue with this is again insurance approvals and the low sensitivity of an exercise treadmill stress test. This PICO poster shows an overview of the process in identifying the problem of overexposures of radiation involved in MPI stress testing, investigating a possible new intervention for nuclear cardiology by utilizing stress-only imaging in MPI stress test, comparisons of different interventions that can tackle the problem, and identifying the outcome of interest with the implementation of MPI stress-only testing. To conclude this economic analysis, the increase in coronary artery disease has caused a major impact on cardiology diagnostic testing and healthcare costs involved. The use of MPI stress tests have been very beneficial in identifying when a patient is suffering from ischemia, but the overutilization of these tests burdens not only the patients but the medical industry as well. The significant radiation exposure, the high cost, and the high time consumption from these tests indicate that the time to act is now. Although the suggestions previously stated certainly do not include everything necessary to reduce radiation exposure, but the need to change how this test is utilized is crucial. With MPI stress-only testing, I believe that it could truly make a difference in nuclear cardiology and patient care. Enclosed, you will find my references utilized during this economic analysis. Thank you for listening and please comment.